The structure of my talk is slightly different. Firstly, let me thank Don for inviting me, and also thank Aspen for asking me to. Initially, I was going to give my own presentation, but we came across some logistical glitches, so we had to use a pre-recorded webinar. And we agreed in the handouts you have, we agree that we'll go through the presentation, and at the end we'll have a brief discussion, whatever questions you want to ask, or it'll be an open session. There's also about 15 questions in the handouts, which afford us about 3 CPD points. So I think that's quite. I'll just run through the answers. We can just go through them as we go along. I'm just going to, before we see the presentation, I just want to make a few quick comments. We are with insulin more than 100 years now, since what, 20? Yeah, more than 100 years. I don't want to do any arithmetic. And what has happened, insulin is insulin. There are 2 main groups. You have your analogs, you have your regular insulins. And within those 2 groups, you have your short-acting, very fast-acting, your intermediate, your long-acting, ultra-long-acting. So insulin is actually quite simple. And I'm glad to speak to my own colleagues, because I've spoken to a few people and they say, oh, the patient needs insulin, refer to physician at secondary care level. And we can't do that. We don't have enough endos, we don't have enough physicians, we don't have enough diabetologists. And besides, these guys are expensive. And our patients cannot, we have to look at, in terms of access, affordability is a very strong component of that. I need to emphasize that we are talking about type 2 diabetes here. There are, you've got your type 1, you've got diabetes after transplants, you've got LADA, you've got a whole, but we are going to be focusing on type 2 diabetes. And we're going to be, I'll try not to be long. And when you look about, I've mentioned, when you look at insulin, the first question that must come to mind is treatment inertia. Doctors are scared of insulin, patients are scared of insulin, and the healthcare system has got its shortcomings as well in terms of making insulin accessible. We all know in the public sector, even in the private sector, you get when a patient attends a local clinic and they're on treatment for diabetes, I can almost tell you what they're getting. Metformin 850 BD. It doesn't matter what or am I wrong? It doesn't matter what your kidney function is. It doesn't matter what your HbA1c is. It's metformin 850. And then we go on to the sulfonylureas. Unfortunately, as a developing country, or low to middle income, or very low income country, as we have been told, I'm losing my train of thought here. I deviated. Yeah. Sorry? Yeah, the sulfonylureas. Sulfonylureas in developed countries are not used much. People now move from metformin to your SGLT2 inhibitors to your GLP receptor agonists, but these drugs are expensive. They have a role, but I want to emphasize as well, insulin has a role as well. And I'm going to urge each one of us, when you diagnose diabetes, please mention the use of insulin at diagnosis. Because we tend to say, let's start off with your orals, we'll see how that goes. You may never, you are messing up with the patient's expectations now. Tell them that, insulin is characterized by an ongoing decline in beta cell function. And for a lot of people, you'll get to a point where you need insulin. And in some cases, I'm sure as we'll see in the presentation, in some cases we have to initiate insulin at the very beginning. And it's very clear cut. It's not rocket science. It's very clear cut. At diagnosis, if your patient's HbA1c is more than 10, you have to really think about insulin right from the beginning. If you're diagnosing AGT or lab glucose is more than 16.7, you are going to need insulin. It is as simple as all that. And as I said, insulin is very straightforward. The one thing that we need to, for a better understanding of insulin use, we sometimes think that we use insulin to bring your sugar down. Okay. Or am I wrong? Yeah. That's the understanding. But there's only 2 occasions when we use insulin to bring, if we are giving a correction dose or where there's high, glucotoxicity and we want to reduce that. And glucotoxicity is important. That's the effect of your glucose. It basically poisons your pancreas. And initially it may be temporary, but the longer we leave that, it becomes permanent. So you destroy your beta cells and you destroy future insulin use. So insulin is basically used to manage, number one, that's what you call your fasting glucose. What insulin does is to try and avoid, excursions. We have to keep a very narrow, about 2, millimeters, millimoles per liter, a very narrow range. So your basal insulins will be doing that to clarify it, maybe just to simplify it. I like to keep things simple because then people, Before breakfast, that's your fasting glucose. And ideally, the glucose you go to bed with and the glucose you wake up with should be more or less the same. And when you eat, you are, this food intake, you are going to get excursions of glucose. That's where your prandial glucose, there we try to avoid those excursions, that upward movement, not to bring the sugar down. And what your basal insulin does basically, there's something called gluconeogenesis. This is production of glucose which happens overnight from the liver. So our basal insulins will be trying to prevent that. And then your prandial insulins, normally your short-acting insulins, would be, the aim there is to keep your postprandial excursions, to a certain limit. We are dealing with a pandemic. We're dealing with an epidemic in terms of diabetes. If I look at this front row in South Africa, out of 9 people, 1 of you will probably end up with diabetes. And that's not great, and things are getting worse. It's not like, things are getting better. Things are getting worse because of a whole lot of other things. You mentioned, food insecurity is a contributor to diabetes. Weight, as you know, South Africans, we are getting heavier and heavier, and obesity and weight really go hand in hand. So it really calls for action, and action from a primary care level, both in terms of early diagnosis. I always say that you don't find that which you're not looking for. We need to screen for diabetes because by the time, at the time of diagnosis, most people have lost more than 50% of their beta cell function. They're really way down. And studies like the UK PDS have actually shown that there's something called the legacy effect. That the earlier you control your sugar, and that also means that, the earlier we use insulin, even 20 years down the line, even if you lose control, you are better off. If you had good control, say, in the first 10 years, and you lose it in the second, you are better off than somebody who didn't have good control in the first 10 years, because they're going to pay for it in the second 10 years. I mean, if that makes sense. So early control is paramount. I don't want to take up too much time because we are not, there's more speakers to come. But I think we should watch this, and if there are points that we need to discuss, or if we have questions based on the presentation from Dr. Kutsia, then we can do that. I'll take the questions and have an open discussion. Thank you. Maybe I should say one or two things about that over-basalization. Over-basalization refers to excessive amounts of your basal insulin. A quick way of looking at it is that if your basal insulin, before you add any prandial insulin, if that's at more than 5 international units per kg, you should be concerned. There's a reason to do that. And the danger of over-basalization, as Dr. Kutsia indicated, there is hypoglycemia. And if you want to get your patient off, really scared and go off insulin, is to allow for very low hypos. And the danger with, she mentioned there also hypoglycemia awareness and hypoglycemia unawareness. Hypoglycemia, if you get hypoglycemia, your sympathetic nervous system, part of the autonomic nerve, should be able to respond to that. You start shaking, you will sweat, and you know that you're in a bit of confusion. You know that something is wrong. But if you now have an autonomic neuropathy, you may not be able to show those signs. And the more hypos you have, the more you are at risk of developing hypoglycemia unawareness. So that over-basalization obviously has to do with the riskier hypos, but with the risk of hypos as well is increased weight gain, because people tend to eat more. If your sugar drops, you want to compensate it with more food, or if you're not feeling well, you would eat more. So I think that's very, very important. And my approach to this is that easy does it. You don't have to bring your HbA1c. You check it at periods of at least 3 months. So you don't have to change things overnight or over weeks. Just easy. And if you have changes in insulin, you can, she mentioned that you can learn as you go along, for as long as you're safe. If you have increments of about 2 units at a time, either increasing your prandial or increasing your basal, you will see the movement without having very large, either excursions or drops in your sugar levels. Are there any more? Can I have questions? Assembly. Sorry? Should we just go to the questions? And as you can see, Dr. Pupoma, in my haste, who's got glasses and doesn't really need them? Okay, there's one here, question number 1. In the SUSTAIN-A trial on semaglutide, what percentage of type 2 diabetes mellitus patients on this therapy achieved an HbA1c less than 7%? Can you just make it quick and interactive? That's 66. And what that study was really trying to show was that, on a background of metformin, canagliflozin that they were mentioning, we don't have canagliflozin in the country. We've got dapagliflozin and empagliflozin. Just trying to indicate that even if you had to use those items, not everybody hits the target. Semaglutide did better than canagliflozin, and yet you didn't get HbA1c. You didn't, not all patients reached the target HbA1c of less than 7. And HbA1c as well, we need to be careful. You can't use 7 for everybody. If somebody is frail or there's other comorbidities, please relax that. If somebody is older, you don't want to push people too tight. Somebody's got bad vision, bad eyesight, whatever. Just give them. You can work on an HbA1c of 7.5. And where life expectancy is shortened, why harass somebody to an HbA1c of less than 7? You can let them go to about 8% and let them enjoy their life a little bit. Yeah. So the HbA1c is flexible, although we talk about, early in the disease, you can push people down into about 6.5%, and they will benefit from that. Like we were talking about the legacy effect, that they benefit years on. But the longer people have diabetes, you need to try to relax that a little bit. Yeah.
Thank you for the informative presentation. I would, for the interest sake, I just want to know how do you go about managing a patient with a recurrent hypoglycemic episode? Because often I'm in the CHC clinic, and often you come across this patient and you think, now must I bring the insulin or maybe try to lower it? Should I stop it completely or what? So in that sense, what is your insight?
Yeah, look, there are many reasons why people may have hypoglycemia. For instance, if you have a patient on insulin and a sulfonylurea, already they are at very high risk of hypoglycemia. I had a patient, what has happened now in the state? They used to have these pens, which were quite useful. Because even if you could see, if you had to give 10 units, you could click the dial, count up to 10, and you are sure that you're giving 10 units. Now they're using the vials. And people can see, people can mix the insulins. It's a nightmare. I saw this one lady, and this is only last week, and I was really concerned because she was getting a lot of hypos. And, when she came back for the visit, she had actually been admitted. Because number one, she didn't pair the insulin to, meal intakes, and it was just a mess. And, one must emphasize, hypos are, that's immediate danger. You can die from a hypo. It is very low and there's nobody to assist you. It's bad news. Hyperglycemia, unless, moderate hyperglycemia, you can live with, you can afford to be, yeah. So I think we need to identify the cause of the hypoglycemia. Like we're talking about over-basalization, where there's too much basal. Remember, what we said about insulin. Insulin should not be used to lower the sugar. It should actually be used to prevent, increases in the sugar. So your basal insulin is to take care of gluconeogenesis overnight so that you don't wake up with very high sugars. But if you are over-basalized, what it means is that you are going to, that insulin that you injected will actually predispose you to hypoglycemic attacks. Yeah. And people sometimes inject and then they don't eat. It happens. Okay? Or you inject, but you don't eat enough. So there are many reasons why people would get a hypo. And I think it's for us to sit down and say, what is really causing the hypo? And obviously that will inform the solution. I don't know if that answers you.